Today we'll be discussing on heart failure drugs in pregnancy and lactation, which drugs are safe and which are not. First, we'll discuss about epidemiology of heart failure in pregnancy. Heart failure complicates approximately 1 to 4 per 1000 pregnancies, with rising incidence due to older maternal age and due to presence of comorbidities. And up to 60% of this presentation due to heart failure, they occur in postpartum period, and it is due to major hemodynamic shift which happens during this period. And congenital heart disease, it dominates as an etiology in higher income countries, while in low income countries like India, still we have the predominance of rheumatic heart disease as an etiology. Postpartum peripartum cardiomyopathy, it remains the leading cause of pregnancy-related heart failure worldwide. And heart failure in pregnancy is associated with increased risk of maternal death, increased risk of preterm birth, and fetal growth retardation. So first we'll be discussing about physiological changes during pregnancy. So cardiovascular changes which happen during pregnancy, so blood volume increases by 40 to 50%, and it will peak at 32 weeks of gestation, while cardiac output also increases by 30 to 50%. Heart rate increases by 10 to 20 beats per minute, and systemic vascular resistance, it decreases, and maximum decrease is found in 24th week of gestation. So this changes that happen during pregnancy, it can unmask the de novo heart failure, or it can even exacerbate the symptoms of heart failure when the woman is a known case of heart failure. Even pregnancy alters the pharmacokinetics. How it alters pharmacokinetics, there are certain cardiovascular changes during pregnancy, there are certain hepatic and renal changes during pregnancy, and also that there are certain GI changes during pregnancy. So there will be increased cardiac output, there will be increased blood volume, and due to that there will be increased distribution of the drug, and there is decreased albumin, so it will lead to decreased protein binding. Other changes that happen during pregnancy are renal and hepatic changes. There will be increased GFR, so there will be faster elimination of hydrophilic medicines, and also there is increased hepatic enzymatic activity, so there will be increased hepatic clearance during pregnancy. Other changes that happen during pregnancy are gastrointestinal. There will be some like nausea and vomiting. It will reduce the oral intake, and also there is decreased motility, and there will be delayed gastric emptying, which will lead to the decreased bioavailability of the drug, and there is gut edema that ultimately lead to the decreased absorption of the medicine. So due to these all changes, what happens is, like standard maintenance doses of certain medicines, they become subtherapeutic due to increased clearance or due to volume of distribution. Like digoxin, if we discuss about the digoxin, it will have increased clearance because it's hydrophilic, and there will be raised eGFR. It will lead to so the same dose of the medicine will be subtherapeutic during pregnancy. What we want to do during pregnancy in heart failure is we want to balance two lives. So we want maternal stability at one side, and at the same time we want fetal safety as well. And we know that cardiomyopathy, it is responsible for 12% of pregnancy related mortality. And what do we want to do here is, like, there will be for management of heart failure, we need guideline directed medical therapy. So we want to stabilize the maternal condition, but certain heart failure medicines, they are teratogenic, and or they do not have safety data available. So due to that, we don't want to use them. So we want to balance maternal stability and fetal safety. So there are certain evidence gaps for heart failure medicines in pregnancy, because randomized trials are not conducted in pregnancy, And most of the recommendations that we have, we rely on the observational data, we rely on registries, and long-term child outcomes are poorly studied. We need registry to improve evidence base, and new heart failure medicines, they require dedicated safety studies, and research, collaborative research is essential in this area. Pregnancy and lactation labeling rule. Previously, there was a A2X pregnancy category rule, but that rule was discontinued in 2015, and because it was like often misleading and did not account for timing or dose or indication or lactation. So now we have pregnancy and lactation labeling rule, which is the current FDA standard, and under this rule, there are 3 sections. One is pregnancy, another is lactation, and third is females and males reproductive potential. Under the heading of pregnancy, there it needs to be mentioned that about the risk summary, then disease associated maternal and fetal risk, dose adjustment required during pregnancy, and clinical consideration, and any registered data if available. Under the lactation label, it needs to be they need to provide the data on drug levels in breast milk, which are the effects on breastfed infants, and effect on milk production. So now this rule is applied, pregnancy and lactation labeling rule. Actually, safest management of the patient, it starts before the conception. So whenever the patient of heart failure is there and patient is planning for pregnancy, we should do pre-conception risk stratification. If the patient, we can risk stratify them according to WHO criteria, or we can even risk stratify them according to different tools available. So if the patient is falling in class 1 category, WHO class, then there will be 2.5 to 5% maternal event rates. And if the patient is falling under class 4, then pregnancy is contraindicated due to high event rates up to 40 to 100% maternal morbidity or mortality risk. So there are certain conditions where pregnancy is strongly discouraged. These are like, if we talk about the heart failure particularly, then if the patient has LV ejection fraction of less than 30% and patient has like a LV dysfunction, but patient is in NYHA class 3 or 4, then pregnancy is strongly contraindicated. And if the patient has severe pulmonary arterial hypertension, then also pregnancy is contraindicated. There are other conditions also that fall in this class 4 WHO classification. Another such classification is Cardiology classification, and according to this score, if the score is more than 4, then there are 41% risk of cardiac event. So in such cases where there is a high score, the patient should be informed about her condition, and they should be discouraged for pregnancy if they are falling in class 4 WHO classification. We should do pre-conception counseling and risk stratification, and if the patient still wants to go for pregnancy, then we should switch certain drugs, and we should patient should be switched from AC inhibitor or ARB or ARNI and MRA to other medicines, which are the pregnancy safe medicine. So they should be switched to beta blockers and other drugs like hydralazine and nitrates. And we should be cautious that while we are withdrawing and while we are switching those medicines, patient may go into heart failure. And if the patient is stable on these alternative medicines before conception, then only they should plan for pregnancy. And general principle of drug use during a pregnancy is that maternal stabilization, it takes the precedence, and teratogenic drugs should be avoided whenever and they should be switched to other medicines when safer alternatives are available. And medicine review should be done before conception when a patient is a known case of heart failure. Multidisciplinary approach is needed in these high risk pregnancies, and shared decision making should be done. Patient should be informed about her condition, they should be informed about the medicines they are taking, and informed consent should be documented in such pregnancies, and continuous maternal and fetal monitoring is critical. There are certain green light therapies for heart failure management. They are the safest. They are the safe backbone. So first line drug is beta blocker for heart failure management, and that is safe during pregnancy. And preferred agents are metoprolol succinate or bisoprolol. And still, though patient is on beta blocker and though it is considered safe, all agents are not considered safe. So safer ones are metoprolol succinate and bisoprolol. And while patient is on beta blocker, we should watch for maternal hypotension. We should watch for fetal growth retardation. So growth monitoring is to be done serially. Vasodilators, which will substitute the RAS inhibition, they are hydralazine and isosorbide dinitrate. They are their safety is like evidenced from the data from the hypertension trial, and we should titrate those medicine as per blood pressure response. They can cause hypotension and reflex tachycardia. We should be watchful for that. And digoxin is safe for red control during pregnancy. It has narrow therapeutic window due to increased renal clearance. So we should monitor levels closely for digoxin. Other orange light therapies are therapies which should be used with caution. They are like loop diuretics and anticoagulation. Loop diuretics should only be used when patient has certain symptoms. They should not be used like preventive use of loop diuretics should not be done. Like prophylactically, that drug should not be used. So it should only be used for relieving active pulmonary congestion or active congestion. And there are certain risks, like it can lead to fetal hypotension and oligohydramnios. And for anticoagulation, if the patient has ejection fraction of less than 30% in peripartum cardiomyopathy, it may be used. And even sometimes when patient has a mechanical prosthetic valve, we need to use anticoagulation. Low molecular weight heparin and unfractionated heparin, they are safe during pregnancy, while warfarin should be avoided during first trimester and during the last month of the pregnancy, and they should be reserved only for the mechanical valves. And if the warfarin dose is less than 5 milligram, it may be used during pregnancy. For NOACs, we have insufficient data for NOACs. So that's why they are not used during pregnancy and not used during lactation. Other red light therapies, like the therapies which are contraindicated during pregnancy are RAS inhibition, so HC inhibitor, ARBs, and ARNI. They are contraindicated during pregnancy, and the risk associated with the use of these drugs are fetal renal failure, oligohydramnios, cranial structural defect, fetal growth retardation, and this risk is highest during the first and third trimester. Mineralocorticoid receptor antagonist MRAs are also contraindicated during pregnancy, like spironolactone and eplerenone, and the risk associated with the use are anti-androgenic effects and potential feminization of the male fetus. That's why it is contraindicated. Other newer therapies like SGLT2 inhibitors or vericiguat or ivabradine, they do not have sufficient data. So for that reason, of lack of safety data, these drugs are contraindicated during pregnancy. Now we'll discuss separately about these all pillars. First, we'll discuss about renin-angiotensin system blockers and SCE inhibitors, ARBs and ARNIs. They are contraindicated due to toxicity, and adverse fetal effects include renal dystgenesis, oligohydramnios, pulmonary hypoplasia, some structural cranial abnormalities, and because of those reasons, it is contraindicated. First trimester exposure is comparatively less harmful, but it is recommended that it should be avoided throughout the pregnancy. Direct renin inhibitor, they also share the similar risk, and that's why they are also contraindicated, and this drug should be discontinued immediately upon the pregnancy detection. And alternative therapies like isolazine and hydralazine and isosorbide dinitrate combination, that can be used in substitution for renin-angiotensin receptor blockers. RNA therapy, it includes ARB component, and that is the reason why it is contraindicated during pregnancy. And we do not have any randomized control data on our use of RNA during pregnancy, and due to lack of data, we do not use RNA, and that is why it is contraindicated. And so after the detection of the pregnancy, it should be immediately stopped. Use of RNA should be stopped immediately. And also that limited safety data is available during lactation, and that is the reason it should also be avoided during lactation as well. Overview of beta blocker. Beta blockers are commonly used for heart failure management and also management of arrhythmias during pregnancy, and safety varies from agent to agent, with labetalol being the safest one, and that most commonly used preferred agent after labetalol is metoprolol, and atenolol has been associated with the fetal growth retardation, and that's why it should be avoided during pregnancy. We should be watchful for maternal bradycardia and also for maternal hypotension, and dose titration should aim for the lowest effective dose, and serial fetal growth monitoring should be recommended. And for beta blockers, we do not have any randomized control data available, and some observational studies are there, and which showed that there is increased risk of small for gestational age infants in the use of beta blocker, and that risk for a small for gestational age infant, it appears agent specific, and that risk is highest with atenolol and lowest with labetalol. Sometimes benefits overweigh the risk when the maternal cardiac indications are strong. Careful counseling and documentation are essential while we are using these agents, and postpartum continuation is often appropriate while using beta blockers. So, according to ROPEC registry, this shows that atenolol has the highest risk of fetal growth retardation, while the labetalol has the lowest risk of small for gestational age babies, and it may be due to shorter half-life due to glucuronidation, and metoprolol has around it has also low risk of small for gestational age babies. Now coming to the diuretic use in pregnancy, loop diuretics are effective for pulmonary congestion and volume overload. We should not do over diuresis because it can lead to it will reduce placental perfusion, and it will lead to oligohydramnios. Thiazide diuretics they are avoided. Only loop diuretics should be used when indicated, and when we are using it, we should monitor electrolytes and renal function. And high dose diuretic should not be used during lactation because it can suppress the lactation, and use should be individualized based on their status. If the patient is dry, then there is no need to give loop diuretics, and if the patient is congested, then loop diuretics can be used. Mineralocorticoid receptor antagonist. Spironolactone has theoretical risk of anti-androgenic effects on male fetus, and so routine use during pregnancy is discouraged. Eplerenone has fewer effects, anti-androgenic effects, but we do not have enough human data available on that. So these drugs can be considered postpartum depending on the breastfeeding plans, and close neonatal monitoring is required if the patient is taking this medicine during lactation. Hydralazine and nitrates, they are considered safe during pregnancy, and it will lead, this combination will reduce afterload, and this can be used as alternative to RAS blockade, and side effects of this medicine include headache and reflex tachycardia. They do not have they have minimal fetal toxicity, and these drugs are compatible with breastfeeding. Digoxin and inotrol. Digoxin can be used safely during pregnancy for the management of arrhythmias and also for the management of heart failure. It crosses placenta, but it is generally safe at therapeutic levels. Serum levels should be monitored frequently during pregnancy because of altered pharmacokinetics during pregnancy. And for the use of inodrops, it should be reserved for the severe decompensated cases, and short-term use is acceptable for maternal rescue, and while we are using these drugs, neonatal monitoring is advised. SGLT2 inhibitors and other new heart failure drugs. These drugs have limited human pregnancy safety data, and certain animal studies, a few animal studies, they suggest potential renal developmental toxicity, and for those reasons these agents are contraindicated during pregnancy and lactation. And ivabradine and vericiguat, they also are avoided due to insufficient data. Other novel heart failure drugs should be discontinued prior to the conception, and they can be restarted in postpartum period based on their breastfeeding decisions. Now coming to the lactation and how to manage heart failure during lactation period. Drug transfer to the breast milk, it varies from agent to agent, and relative infant dose, it will help in estimating neonatal exposure. Premature infants, they are more vulnerable to these effects of the medicines, and some heart failure drugs, they require cessation of breastfeeding, and for that shared decision making is essential, and infant monitoring should be done when the patient is taking certain medicines for the management of heart failure. So let us discuss about the pillars which are required for the heart failure management. For ACE inhibitors, during pregnancy it is contraindicated, and during lactation ACE inhibitors can be used, and preferred ACE inhibitor for the management of heart failure during lactation are enalapril or captopril, because it has the lowest breast milk transfer. And while the patient is on those drugs, we should monitor neonatal weight. MRIs are contraindicated during pregnancy, but they can be given during lactation. Spironolactone is considered safe during lactation. Beta blockers can be given during pregnancy, and we should try to avoid atenolol because it has tendency to cause small for gestational age babies. So we should prefer rather medicines like metoprolol succinate or labetalol or bisoprolol. During lactation also beta blockers can be used, and metoprolol succinate is the preferred agent, and while patient is on this drug, we should monitor neonatal heart rates. SGLT2 inhibitors and ARNI, they are contraindicated during pregnancy as well as during lactation due to lack of data. So if we look at the relative infant dose and monitoring, then which drug should be used during lactation for the management of heart failure? For in the ACE inhibitor class, enalapril is the safest one due to low breast milk transfer, and we should monitor infant weight if patient is on enalapril. Metoprolol succinate is the drug of choice in beta blocker category, because it also has low relative infant dose, and we should monitor for bradycardia and lethargy and poor feeding if the patient is taking. We should monitor for bradycardia in babies, and we should look for lethargy and poor feeding in babies if the mother is taking beta blocker. Loop diuretic should be used with caution because it reduces milk production, and we should monitor infant weight. Anticoagulation like warfarin is compatible during lactation as it is a polar molecule and it does not cross into the milk, and anticoagulation with low molecular weight heparin can be given safely during lactation. So to summarize, which drugs to be given during pregnancy and which drugs can be safely given in postpartum period and which drugs should be avoiding during this period. So if we look at the first trimester, Then SE inhibitors are contraindicated, ARBs are contraindicated, ARNI is contraindicated, MRA and SGLT2 inhibitors are contraindicated throughout the pregnancy, MRAs and SGLT2. Then beta blockers like metoprolol succinate can be given safely during the first trimester. Then hydralazine is like orange light therapy. It should be used with caution because it causes hypotension and it causes reflex tachycardia. Beta blockers, bisoprolol and metoprolol succinate can be given safely during the second trimester. MRS and SGLT2 inhibitors should be avoided. Same is for the third trimester as in the second trimester. And during the lactation, we should use we can safely use SE inhibitors, and safest being the enalapril or captopril, and for ARBs, candicertan or irbesartan or valsartan. ARNIs are contraindicated during lactation. Then beta blockers, metoprolol succinate can be given during lactation. MRAs, spironolactone can be given during lactation, while SGLT2 inhibitors are contraindicated during postpartum period while patient is breastfeeding. So some patients who are like heart transplant cases and they are becoming pregnant, so they are taking immunosuppressant. For the sake of that reason, I've taken the use of immunosuppressants also. So if the patient is heart transplant case and if she is pregnant now, then which drugs can be used during the pregnancy and which can be used during lactation? So calcineurin inhibitors like cyclosporin or tacrolimus, they are safe during pregnancy and the lactation. mTOR inhibitors like everolimus or sirolimus, they are also acceptable if needed to be used during pregnancy and lactate. And for those drugs in lactation, we do not have data available, and for that reason they are contraindicated during lactation. Azathioprine is usually compatible with breastfeeding and also considered safe during pregnancy. Mycophenolate derivatives, they are contraindicated during pregnancy, and they are also not recommended during lactation. And this drug should be stopped at least for more than 6 weeks before conception. Now coming to lipid-lowering therapy in pregnancy and lactation, many cases have like LV dysfunction secondary to ischemic heart disease. So if the patient has atherosclerotic cardiovascular disease and heart failure, these cases, in those cases we may consider using statins. Previously it was considered like it was said that it was contraindicated till July 2021, and after July 2021, then FDA update said that there is lack of evidence to say that this drug should be contraindicated during pregnancy. So this drug is now no longer contraindicated during pregnancy, but still it is contraindicated during lactation. And this drug use may be considered if the patient has familial hypercholesterolemia or established atherosclerotic cardiovascular disease. And if there is inadvertent conception while the patient is on statin, it does not require pregnancy termination, but close monitoring is advised. Management of atrial fibrillation and atrial flutter during pregnancy. The safe drugs are beta blockers, verapamil, and digoxin. If rhythm control is needed, then we can use sotalol, flecainide, or propafenone. And IV procainamide is used only for the treatment of atrial fibrillation with pre-excitation. If we talk about the safety, flecainide can be used during pregnancy, but certain adverse effects should be monitored, like it can cause maternal visual disturbances, it can cause prolong QT interval in maternal, it can prolong maternal as well as neonatal QT interval, and it can cause cholestasis of pregnancy and decrease fetal heart rate variability. And for propafenone, we do not have enough data for use during pregnancy. And sotalol also leads to the increased risk of torsades due to QT prolongation, and it is typically used for the treatment of fetal arrhythmias. Amiodarone is considered unsafe during pregnancy, so it should not be used. it should only be used if potential benefits outweigh the significant risk to the fetus. Risks include neonatal hypo or hyperthyroidism, neonatal or fetal bradycardia, preterm birth and growth restriction. So amiodarone is considered unsafe during pregnancy and lactation. In summary, we can say that we should focus on pre-conception counseling in these high-risk pregnancies. RAS blockers are contraindicated during pregnancy. Beta blockers and hydrolysins are safe alternatives. Multidisciplinary care is strongly recommended. We need to categorize the patient as per their risk, and postpartum transition to standard heart failure therapy is advised, and still we have certain evidence gaps, and to fulfill those gaps we need further research. Thank you.